Infections caused by Acinetobacter, and particularly multi-drug resistant and carbapenem-resistant Acinetobacter, are considered a real urgent public health problem because we don't really have drugs to treat these organisms. The antibiotic options are scarce, but hopefully there's hope in the future with new drugs. Today, we are going to discuss with experts on the topic the treatment and therapeutic approaches for Acinetobacter infections. So the objectives of this podcast is to discuss Acinetobacter as an opportunistic pathogen, elaborate on therapeutic approaches for Acinetobacter infections, and deliberating future approaches for these multi-drug resistant organisms. Welcome to Editors in Conversation. This episode is brought to you by the Antimicrobial Agents and Chemotherapy Journal, available at aac.asm.org. I am your host, Cesar Arias. I'm the Editor-in-Chief of Antimicrobial Agents and Chemotherapy, and this podcast is supported by the American Society for Microbiology, which publishes AAC. Don't forget to check our latest issue of AAC, available at aac.asm.org, with outstanding papers on mechanisms of resistance, pharmacology of antimicrobial agents, epidemiology, clinical therapeutics, and others very interesting papers. I want to announce two upcoming events sponsored by AAC. We're going to have on November 30th, and we're recording now before Thanksgiving, a Betalactamase nomenclature workshop with world leaders in the field, and we're hoping to come up with a specific strategy for publication and a consensus for reporting Betalactamase alleles. So stay tuned. We will report on that, and there will be a publication on AAC. The other interesting event is the AAC is sponsoring the 5th Texas Medical Center Antibiotic Resistance and Stewardship Conference, which takes place in Houston, Texas, from January 19 to 21st of 2022. We're hoping to have an in-person and remote registration available. It's an outstanding program which incorporates the NIH-funded Antimicrobial Resistant Leadership Group and all the T32 training programs in the country. So the website is amr2022.blogs.rice.edu. So, gentlemen and ladies, we are now joined by experts in the field, and I'm very, very happy to introduce our guests. The first one is Dr. Yohei, who is professor and director for the Center for Innovative Antimicrobial Therapy at the University of Pittsburgh Medical Center in Pittsburgh, and Dr. Joseph Patrick Hornak, who is an ID fellow, and I love to have ID fellows in the podcast, so this is great. I'm very happy to do that. He's a fellow of infectious diseases at the University of Texas Medical Branch in Galveston, Texas. So, gentlemen, welcome to the podcast. So let's start with you, Yohei. And there is a reason why we scheduled the podcast, because people, are asking how to treat Acinetobacter infection. So give us a perspective why Acinetobacter is such a bad drug and such a difficult drug to treat.
Sure, Cesar. So Acinetobacter, in particular Acinetobacter baumannii, has several characteristics that make them a perfect hospital pathogen. The species has very plastic genome, which makes it easy for them to pick up new genetic elements such as drug resistance genes. Also, it's very resistant to desiccation. So I actually experimented this in our lab. Under completely dry condition, they're 100% alive over 2 months. It's pretty amazing. And then there's a host of virulence factors that makes it especially problematic in the context of hospital-acquired pneumonia or ventilator-associated pneumonia. Now, it's well recognized as one of the top drug-resistant pathogens now, but Acinetobacter was never always drug-resistant. If you go back in the literature, in 1970s, apparently people were treating Acinetobacter infection with drugs like ampicillin or gentamicin. In the 1980s, it started to evolve drug resistance, and in 1990s, 1990s, carbapenem-resistant Acinetobacter baumannii appeared in hospitals in the U.S. as well as in some countries in Europe. And in 2000s, it has really spread across hospitals around the world.
This is a great introduction. Just following that thought, Yohei, so why now has become such a problem? Do you think it's due to the availability to capture antibiotic-resistant genes? And I know you have been working on the genomic epidemiology of these organisms and how they disseminate. So give us some clues on why now have this rise of resistance in these organisms.
Yeah, sure. It's likely to be all of that, but I think an interesting evolutionary aspect is that it probably started out as from an environmental pathogen, and at some point it entered the hospitals. Certain clones that were especially well adapted to healthcare environment were selected under various selective pressure from antibiotic use. And at this point, there are only a few major clones or lineages of Acinetobacter baumannii that are particularly resistant and problematic in hospitals around the world. So it's really a kind of clonal phenomenon that we have observed. And this is in contrast with, for example, when you think about Pseudomonas aeruginosa, that's another big problem in hospitals, but there are many different strains of Pseudomonas that have independently become drug resistant and have infected patients. So there's, I think, some interesting features of Acinetobacter.
Great. Very interesting. Patrick, you're an ID fellow, and you very recently published a paper, or you were the lead author of a paper in which is one of the challenging clinical cases on antimicrobial resistance, which I think have been so useful for people to understand resistance. And I wanted to have you here in the podcast to talk about that case, because that highlights what we've been seeing about the emergence of pan-resistant, basically, Acinetobacter. And now you guys tried new drugs in compassionate use, and that seems to work. So why don't you walk us through the case, so we put everything in context?
Sure thing. Thanks again for having me here. Very happy to talk about this case. This was definitely a signature case for my infectious disease training. Personally, it taught me a lot of what I know about Acinetobacter infections, and taught me 100% of what I know about compassionate use protocols, which is now a lot. And I hope you all find it similarly interesting and instructive as I have. And so this particular patient came to our hospital as a transfer from an outside institution. This is about a year ago now, during one of our big COVID-19 surges here in Texas. And so it was late fall. It was around this time. And she didn't arrive at our hospital in good shape. She had already been intubated for about a week. She had gotten the typical cocktail of remdesivir and steroids and convalescent plasma, which we were doing at the time. To our knowledge, she didn't receive any significant antibiotic exposure at the outside hospital, but she certainly was in the intensive care unit there. And we know that's a risk factor for acquiring these Acinetobacter baumannii isolates from nosocomial environments. And before her COVID-19 infection, she was actually quite healthy. She had hypertension, hyperlipidemia, well-controlled diabetes. And when she arrived, our ICU team did a really good job thinking about superimposed infections, doing a workup with blood cultures of the sputum and the urine. And they didn't really find much at first, other than some regular respiratory flora. She did get a few days of meropenem as presumptive therapy for a possible ventilator-associated pneumonia, because she was febrile and she did have a vasopressor requirement at the time. And in fact, she did really well at first. She was extubated after about 2 weeks at our institution, but then things quickly went awry and really went backwards, and they went backwards fast. She had to be re-intubated and was put back on vasopressors within about 24 hours of being extubated. And our ICU team was really on top of it again and repeated a good infectious workup and restarted antibiotics empirically, thinking that maybe this was a central line associated bloodstream infection or possibly a ventilator associated pneumonia. So our antibiotics were meropenem and vancomycin when the diagnosis was made of this, what ultimately turned into a pan-drug resistant Acinetobacter isolate. And that's, of course, when the infectious disease team became involved. We were not involved prior to that. And so we launched really our first attempt at a salvage regimen at that point.
So sorry, Patrick. So remind me, the organism came from the sputum. Where was that isolated from the blood?
Yes, it came from the sputum. We did check the blood at that time, and those cultures were negative. And so it was just a HAP-VAP, if you will.
Okay.
And so at this point, the infectious disease team is involved, and we're trying our first combination salvage regimen. We added high-dose sulbactam, we added polymyxin B, and we tried to optimize for meropenem to the best that we could. And so we went from a 30-minute infusion interval up to the 3-hour extended infusion. And this is where I really give a lot of credit to our pharmacy colleagues. They help us out a tremendous amount in some of these challenging cases, trying to really get these PK and PD metrics up to snuff, if you will. But unfortunately, in this case, it wasn't enough. And so we had to start thinking creatively.
Okay. So sorry to interrupt now there. So this case is so important that I want to dissect it. So
sure.
Dr. Doi, so what do you think? So when people start, you come, like Dr. Hornak, a carbapenem-resistant Acinetobacter with, resistant to many things. What do you think of those initial regimens? So, using high-dose ampicillin sulbactam because we don't have sulbactam alone. So using a polymyxin, which, the data is really not very enthusiastic, and then continuing with the carbapenem, maybe trying to optimize the pharmacokinetics of this, infusions of that. So what do you think with that first approach? And we continue developing the case.
Yeah, that's a great question to which I don't think we still don't have a definitive answer. The backbone at this point continues to be colistin or polymyxin B in many settings, since it's probably the most consistently active agent against Acinetobacter baumannii, including carbapenem-resistant strains, at least in vitro. However, as we know, polymyxins have many issues in terms of pharmacokinetics, toxicity, development of resistance, and there are a lot of, especially in vitro and some animal data to suggest combination therapy that includes colistin may improve activity or outcome. And the most commonly used combination is a polymyxin plus carbapenem, which I think was a part of your regimen, Patrick, as well initially. Mm-hmm. But there have also been a couple of landmark clinical trials where colistin alone was compared with colistin plus carbapenem, meropenem, and neither of these two randomized studies really showed definitive benefit of adding carbapenem. But in a sense, we're kind of back to square one in terms of how to optimize a treatment based on colistin. And you also mentioned sulbactam, which is an interesting one because it is a beta-lactamase inhibitor, but it also has intrinsic activity against Acinetobacter. And there's some work suggesting presence of synergy between sulbactam and colistin. Now, over the past 10 years or so, the MICs of sulbactam have creeped up, which makes it a little bit challenging and uncertain. So in the end, we often end up sort of throwing all these agents into the mix, as I think has been done initially with this case.
So Patrick, tell me a little bit, what was the dose of this ampicillin sulbactam that you guys try? And I have a follow-up questions after that.
Sure. So we were doing sulbactam 3 grams as a total component every 4 hours. And so we were giving 6 doses a day.
Okay. And do you have any other toxicities? When you mentioned that it wasn't enough, what happened to the patients, or what kind of toxicities were you having?
So thankfully, we weren't having any toxicities from the polymyxin, if that's sort of what you were asking. Thankfully, that was one of the organs that she kept in good shape throughout this infection, were her kidneys. But she continued to have a vasopressor requirement, actually quite high on norepinephrine through this entire time, and had high requirements on the ventilator. And so we weren't really seeing any expected improvement that we would like to see from a very aggressive antibiotic regimen otherwise. And so that's why we weren't really attributing any kind of significant headway from this very otherwise optimized regimen.
Yeah. So one drug that you haven't mentioned, and that's something that I sometimes throw in the mix, is the glycylcyclines, or some of the new tetracyclines that now we have available. Patrick, do you remember the susceptibility, for example, for tigecycline at that time, or if there was omadacycline available, and particularly for pneumonia, maybe tigecycline as put it in the mix? Was that at that consideration?
So that's a great question. That's actually the next thing I was planning to bring up. This isolate was resistant to tigecycline. It was fully resistant to tigecycline per the susceptibility profile that we had run by our institution's microbiology lab. But we were intrigued by some pretty nice in vitro data that suggests that eravacycline in particular can have nice low MICs for Acinetobacter isolates, even when tigecycline or minocycline, some of these other tetracycline family antibiotics are resistant or have elevated MICs or non-susceptible. And so that was actually our next move after a few days of trying the 3 drugs, as we went to a quadruple regimen. So yeah, that was
which one did you
question.
decide to? Which one did you decide to add?
We decided to go with eravacycline since that was one that we had on formulary at our institution, so we knew that we could get it and start it basically immediately, and that was why we chose that over omadacycline, for instance.
Okay, so Yohei, can you give us any insights about these new tetracyclines and the tigecycline and minocycline differences for Acinetobacter?
Yeah, sure. So tigecycline was for the first one to come out, and now we have eravacycline available, at least in the United States. So eravacycline is a fluorocycline. It has incrementally higher activity against Acinetobacter baumannii compared with tigecycline. So in a situation where you sort of have to use one of these agents, it probably makes sense to go with eravacycline if it was available at your institution, acknowledging that this is all based on in vitro findings with almost no clinical data to support it.
Okay. So what happened, Patrick? This is like a suspense now going on to the end of what happened to the patient. So you added eravacycline, so you now have a patient on polymyxin B, ampicillin sulbactam, meropenem, and eravacycline, right?
Yes.
Okay, so what happened?
So at this point, we are, and I think this reflects a lot of the sort of boots on the ground, very minute by minute decision making that goes on in the ICUs and on the floors, is that oftentimes you're doing a lot of things at once and you're sort of planning things. It's not always a stepwise sequential process as we would nicely and neatly like to have happen. So we were grabbing for eravacycline because we had it available, but we also were a little skeptical because we didn't have much or really any in vivo data that would support this sort of a very complex, very critically ill sort of situation. So we were scouring every available piece of literature, looking in conference abstracts, and we're this is where we started to think about using cefiderocol, which was actually, I think, the first or second time maybe we used it at UTMB period. And we also encountered a conference abstract from ID Week in 2019 from actually looking at what we now call sulbactam, durlobactam, and I know we're going to talk more about both of those agents as we go forward. So a lot of moving parts all at once. And cefiderocol is not on our institutional formulary, so we went ahead and ordered that, and we knew that was going to take a couple days to get shipped and delivered and started. So we wanted to have that sort of in our back pocket processing while we were trying ribavacycline to see what headway we could make. And we really started with a simple email to Entasis Therapeutics, which is the drug manufacturer for this new Betalactamase combination, sulbactam, durlobactam. So more to come.
Okay, so great. So now we go to the next level, which is cefiderocol, Yohei. You know, a drug that this, you know, distributed by Japanese, right? You know, I love the concept of the science of this drug. A catechol cephalosporins, like, you know, called the Trojan horse, to use the iron sort of transported of bacteria to try to get into the periplasmic space, you know, and concentrating in important concentrations. We've used that. You know, we know about the weaknesses of this drug as well. What do you think, Yohei, about cefiderocol and Acinetobacter?
Yeah, thanks, Cesar. So there has been several attempts to develop siderophore beta-lactams for clinical use, but cefiderocol is really the first one that has made it to the clinic. And as you mentioned, it leverages the ion transport system and is also designed to be stable against multiple beta-lactamases, including, pretty much across class A through class D beta-lactamases, which really gives it a potent activity across gram-negative pathogens, including Acinetobacter baumannii. If you look at surveillance data, almost all, if not all, Acinetobacter baumannii clinical isolates are susceptible to cefiderocol. There is some strains that are resistant to Acinetobacter baumannii. The mechanisms are, I think, still being investigated, and possibilities include, for example, mutations to the ion transport system. Also, there might be involvement of some rare beta-lactamases, which the drug is not stable against. So there's a lot of enthusiasm over this this new cephalosporin. One caveat is the data from one of the pivotal trials, which was called Credible CR, which was a relatively small randomized trial looking at cefiderocol versus best available therapy against carbapenem-resistant infections. And what they found was that there was some excess mortality in patients who received cefiderocol or cefiderocol-based regimen against Acinetobacter baumannii infection. Now, this was a relatively small trial. There were more sick patients in that arm, and it could represent some failure of randomization. But nonetheless, I think we should be really careful when we're going to use cefiderocol against Acinetobacter baumannii infection, even when the initial susceptibility testing is susceptible.
Right. So before we move on, now that you mentioned now the beta-lactamases, let's remind the audience what are the common beta-lactamases that you find in Acinetobacter, and the stability potentially of cefiderocol against those carbapenem-resistant, Yohei.
Yeah, sure. So most Acinetobacter baumannii strains produce at least two beta-lactamases intrinsically. One is the ADC beta-lactamase, which is pretty much an AMP-C beta-lactamase. So it's active against penicillins and cephalosporins. And the other one is what's called OXA51 group beta-lactamase. It's considered to be a weak carbapenemase and produced generally at low level. So that's what they have at baseline. But the vast majority of the carbapenem-resistant strains that are problematic in hospitals additionally produce a plasmid-mediated OXA carbapenemase enzymes. And there are several kind of groups of these enzymes, including OXA23, OXA40, which used to be called OXA24, OXA58, OXA143, and I think OXA235 now. But by far the most common one is OXA23, which accounts for probably 3/4 of plasmid-acquired OXAs found in Acinetobacter, and cefiderocol is considered to be stable against these enzymes.
Great information. So Patrick, now go back to your patient. Then did you add cefiderocol or did you stop all the drugs? And so what happened in that interim before you got to this company to get something compassionate use?
Sure. So we had about 48 going on 72 hours with the quadruple regimen. So the high-dose sulbactam, the polymyxin B, the high-dose extended infusion meropenem, and the eravacycline. And over those 2 to 3 days, there really was no significant difference relative to the preceding several days on the 3 drugs. So we were not clinically that convinced that the eravacycline addition was something that we needed to necessarily keep, but that we probably should just wipe the slate clean. We have these 2 new super beta-lactam agents coming into our institution for the first time. Let's try them out. And I think that the real rationale for why we decided to use both really goes back to the one of the initial comments that I made when we started going through the case was that we usually are thinking about these really difficult to treat resistant Acinetobacter infections as something where you're using multiple drugs at once, hoping that at least one thing is going to be susceptible and effective. And we knew that it was going to be several days until we could get any sort of confirmative susceptibility testing, et cetera. And we didn't want to necessarily just hedge our bets on monotherapy with one or the other.
So just to clarify, sorry to interrupt, to clarify to the audience, then you decided to stop all the drugs and started regimens that included cefiderocol and then compassionate use of a drug that is not yet in the market called durlobactam-sulbactam, right?
Correct.
So tell us about that. How was that process?
That was this was my first week on the general ID consult service after coming off of a research month, and our census was in the 40s because of all of sort of COVID-related cases, and then I'm thrust into my first emergency use, expanded use protocol. So it was quite the experience.
Great experience.
Yes, I'll never forget it. And basically, it started with an email to the drug manufacturer, Empirical Therapeutics, are out of Massachusetts, and they're working specifically on difficult to treat resistance in gram negatives, and have really focused a lot on Acinetobacter, and have this new drug, as has been mentioned, it's called sulbactam durlobactam. And it started with an email, and within about 20-30 minutes, we had a response from the chief medical officer of that company, who walked us through the process, which would involve doing an individual emergency use authorization from the FDA, various paperwork for the pharmaceutical company, And then our own institutional IRB proceedings had to happen as well. Somehow we had all of that done, various phone calls, communications, emails, and the drug was infusing into the patient within 72 hours.
Fantastic. This is a great example, guys, of the epidemic of multi-drug resistant organisms. We were, hit with COVID. We had to do many of these things, as well. But this is we call the silent epidemic. So, Yohei, tell us why they decided to go with that drug called durlobactam and with sulbactam. Why is that good for Acinetobacter?
Yeah, this is really an interesting combination, right? So durlobactam is a novel beta-lactamase inhibitor of DBO class, which has a similarity with avibactam and
relebactam.
Relebactam. But it's chemically designed in a way to be stable against these carbapenem-resistant that we just talked about. So it's sort of an improved version of avibactam, if you will. And as a result, it inhibits beta-lactamases, including from class A, B, C, and now class D from Acinetobacter baumannii. And even more interesting, it's combined with sulbactam, right? So sulbactam we think of as a classic beta-lactamase inhibitor, but as was also brought up earlier, is intrinsically active against Acinetobacter and some limited number of gram-negative species. So here, sulbactam is being used as the actual beta-lactam, and that is combined with sulbactam. And then as a result, in surveillance studies, this combination has been shown to be active against, I'd say, over 95%, close to 98% of Acinetobacter baumannii that's collected from hospitals.
Great. So this new drug, Patrick, you are a fellow giving a new drug for the first time to a patient. So tell us what happened. I mean, when the patient got the drug and then you are infusing that with cefiderocol. So tell us what happened.
So what was really, I think, convenient is that the timing of all of this lined up really well. This patient only got 2 doses of cefiderocol before they got their first dose of sulbactam durlobactam. So I think we can really attribute the success to the combination of the 2 agents. It's not like she had a lead-in of 3 days of cefiderocol and had started to get better, and then we maybe finished the job with sulbactam durlobactam. They really were used together basically from the start of when we had them available. And fortunately and miraculously, long story short, she basically got better. And she got better really, really quickly, which was a stark contrast to what felt like an eternity. But realistically actually was about a week and a half of this ongoing onslaught of different antibiotic changes and aggressive pulmonary hygiene measures that respiratory therapy and the pulmonologists were working on. And really within 48 to 72 hours, her persistent fevers had completely resolved. She was weaned off of her vasopressors, and she was also weaned down to minimal ventilator settings, which was, like I said, just a complete night and day difference. It's impossible to argue that these 2 weren't giving us exactly what we had hoped for all along, which was a meaningful therapeutic effect in our patient. And it was really, really exciting to be a part of that.
So have you followed this patient? Was this patient waiting for ventilator? And did she make it at the end?
Absolutely. She's done beautifully well. She was in the hospital for about 2 weeks after we started the antibiotics, and we gave a total 14-day course. And then she was discharged on that same day actually to go to a long-term acute care rehab to get physical therapy and rehabilitation. And has since been discharged home. We actually follow up with her via email and telephone from time to time, and she is back to living a completely normal life. And that's truly the best case scenario of what was a very challenging case.
Well, this is unforgettable for a fellow. You never forget this case. So, Yohei, as an experienced clinician, what do you think of this? This is what I'm saying. The drugs save lives and antibiotics save lives, and these are precious drugs. And so what do you think about the empiric approach of this with these still new drugs with not much data, but when you have these outcomes that are so favorable?
Yeah, right. Because I was reading your paper, Patrick, and I was in suspense, like, oh, this is not going to go down well. But it ended happily, so I was really happy, glad to see that. And even better news, I think, is that after that, the clinical trial of sulbactam and durlobactam turned out positive results. So this was a trial that was specific to pneumonia and bacteremia caused by carbapenem-resistant Acinetobacter pneumonia, and half of the patients received sulbactam, durlobactam, plus the imipenem-cilastatin backbone. The control groups received colistin plus imipenem-cilastatin, and the all-cause mortality was quite lower in the sulbactam, durlobactam group, if not statistically significant, 19% versus 32.3%. And I think it's going for FDA approval. But I think you're doing this without that knowledge at the time, right? Really a heroic effort. Now, the trial was done with imipenem as the partner. As was highlighted in your case, we do have cefiderocol now, and this combination, I think, makes sense. Your case is probably the first kind of clinical data, if you will, and I think we really hope to see more kind of clinical experience and reports come out after this.
Yeah, and we're very proud to have this paper published in AAC. So you go and read the details of these papers. So this is a great podcast. I get very excited when I can put this into perspective of a patient. So I also been asked recently about Acinetobacter infections in other tissues or other infections. For example, urinary tract infections, right? That sometimes I know it's difficult to say what if it's really truly an infection versus a colonization. But then you start thinking what drugs get there, and you can really use compassionate use in all of these patients. So any of you want to say for urinary tract infection, any particular recommendations when even the tetracyclines or glycycyclines might not be the best there either? Any other recommendations?
Sure. UTI from Acinetobacter, as you mentioned, like it's even hard to define as a clinical entity, right? But occasionally there are cases where we think this is a urinary tract infection. In addition to all the kind of novel approaches that we talked about, I think one interesting point to highlight is that colistin is a prodrug, right? That's given to a patient, and this CMS is the prodrug that the patient actually gets, and that goes into the urine, right? So and then is converted to the active colistin in the urine. So in theory, if you have a true Acinetobacter urinary tract infection, a treatment with colistin might make sense, but not polymyxin B, because it is given as an active drug and does not go into the urine well. So generally, we kind of consider these two polymyxins as kind of interchangeable, but this might be a situation where there might be a clinical difference.
Great. Patrick, any comments? Now that you become expert in Acinetobacter infections?
I would say, and maybe this is a semi-biased institutional perspective, but we don't use a lot of aminoglycosides at UTMB, and I don't think we do in general, because a lot of clinicians have been scared away from nephrotoxicity and ototoxicity. And so sometimes, and not just for Acinetobacter, but other multi-drug resistant gram-negatives, they're your only class that are left, and I think that those are a potential option. I don't know if I've ever seen an Acinetobacter UTI. I think that coming up with that diagnosis, as has been mentioned, is a little nebulous as a concept, and sometimes maybe there's just a catheter that needs to be exchanged, and that's the treatment. And so I think sometimes just taking a step back and doing some of these older, easier treatments, there might be merit there.
Great. Just to conclude this wonderful conversation, what's in the future? What's in the pipeline, Yohei? What can you tell us that, the world of beta-lactamase inhibitors is exploding right now, and I'm very happy that we will have several combinations that may be interesting. Anything that looks interesting for us in Acinetobacter?
There are even additional newer beta-lactamase inhibitors that are in pipeline, and quite honestly, I think that the field is getting a little bit saturated now that even Acinetobacter is covered. And I think I'm most interested in how, especially this sulbactam, durolobactam, will progress clinically. And there's, of course, for example, therapy with phage cocktails. I think that really gained traction when AAC reported a case of a very sick patient who was successfully treated with phages against Acinetobacter baumannii. So I think, lots of exciting developments moving forward.
Yeah, so we will hopefully have a podcast on phages. I think it's time now that is getting tracked. I continue to be in the skeptical camp. I think the logistics for that is going to be very tough, but if you have the ability to do that and evolve phages on regular or by hour, probably it's going to work. Okay, Patrick, I'm going to give you the last word of the podcast. Tell me what do you think is the future, and what did you learn about all this?
Well, first, thanks again for the invitation. It's been this has been a super great pleasure, and I've really enjoyed it. And I try to tell everybody that I can about this case. And I think the biggest take home for me, I think that this case and all of the effort that's being done for highly drug-resistant Acinetobacter and other pathogens highlights the importance and the value of teamwork and sort of reaching across aisles and barriers. And so it's medicine working with pharmacy, working with microbiology, working with the pharmaceutical industry, in and outside academia. I think that that's where we're going to win this war against difficult pathogens. And that was my biggest take-home message biggest take-home learning point, I think, from this case. And
fantastic. Well, we're at the end of this podcast. A wonderful conversation. We learn a lot as usual. This is Cesar Arias, Editor-in-Chief of AAC, signing off. Thank you very much.